Hello? Oh, here we go. So the next step for this evening is we're going to have our three presenters. They're going to come up and get organized, and they have about 15 minutes each, and they're going to be presenting on aspects of opioid use disorder treatment with medication-assisted treatment and the standards of care. We're going to wait for the whole panel to finish with the presentations and then open it up for questions to the panel. And again, just use a mic so everybody can hear your question. And then after that, we'll give a few minutes for tables to have a little conversation for 5 minutes or so. And then really just open it up again to some group discussion facilitated by Dr. Duhigg and Dr. Bhatt. So you can feel free to ask further questions of the panel, but also ask questions of each other, ask questions of anybody else who's in the room. What our purpose today, you all are hand-selected to be at this medical leadership meeting tonight. We really want to get people going back to their communities and being able to understand the standards of care for medication-assisted treatment, and then in the discussion time, really letting everyone here know, and we're documenting it tonight, what more is needed, what barriers you're facing, what other things you think need to be addressed, as Dr. Grace and Dr. Lindstrom were talking about, so that we can use the resources that we have, which are really quite substantial for a SAMHSA grant to address opioid use disorder. So without further ado, I'll introduce the speakers. You guys can come on up. Dr. Snehal Bhatt is going to be presenting Dr. Dan Duhigg and Dr. Andrew Shee. Dr. Bhatt is an board-certified psychiatrist and certified in addiction psychiatry. He is a provider at the UNM Addictions and Substance Abuse Programs. And he's also the clinical lead for the state targeted response and the state opioid response grants under SAMHSA. So he helps, along with other folks like Dr. Bonham, to guide our clinical decisions around best practices for opioid use disorder treatment. Dr. Dan Duhigg is a doctor of osteopathic medicine, and he works with Presbyterian Health Care Services. He's the clinical program medical director for behavioral health, and he is also part of the STR and SOR clinical leadership team. It helps to guide our processes and the things that we're putting on our resources in the network of care. And Dr. Andrew Shee is a professor of pediatrics and family and community medicine, and he leads the FOCUS program that works with infants who have been prenatally exposed to drugs and alcohol and their families. So I'm going to have all you guys can present. You have microphones, but you're welcome to use this one as well. And we'll start with Dr. Bhatt.
Thank you, Julie. And it's a really great honor to be here and speaking in front of you guys. And it's really good to see familiar faces and some people that I've interacted with but meeting for the first time. And it's really cool to see people who are doing all aspects of providing care for our patients, right? People doing prevention work, people doing like frontline treatment of opioid use disorder, and people doing harm reduction stuff, right? So we've got the whole continuum represented here. So welcome, everyone. And Dr. Duhigg and I have sort of a combined presentation, right? With the goal of really laying out what the best practices are for treatment of opioid use disorders, what the standards of care are, what's evidence-based, and what is not, right? So I'll start the process off, and then Dr. Duhigg will take us home. And thank you, Flor, for pulling up our presentation. About 15 minutes, correct? Okay, great. All right. So, to start off, the first point that I'm gonna make, right, is that detoxification alone is not a successful treatment of opioid use disorders. It is not evidence-based. Appreciate that addictions are chronic illnesses similar to diabetes, hypertension, or asthma, and learn that maintenance treatments with an FDA-approved medication is the standard of care for patients with opioid use disorders. And finally, we'll appreciate what some barriers to treatment are and how to address them, right? So this is a quote from that I actually heard back when I was a fellow along with Dr. Duhigg in 2009. I was at a conference, Dr. Ling was presenting, and he said this: detoxification from heroin is good for many things, but staying off heroin is not one of them, right? So it just stayed with me, so I figured I'll start off with that. This is a dramatic study that came out in 2003. Two groups, right? And I've got this laser pointer, so I might as well use it, right? This group with the red lines is the group that's maintained on buprenorphine. And this line that crashes and burns is the group that's detoxified using buprenorphine. And what do you see? So 1 year out, the group that's maintained on buprenorphine, 75% of them are still in treatment. And treatment is good. People stay in treatment, we help them. Every major study has shown that. On the other hand, the group that's detoxed off, within 2 months, every single person has dropped out. And even more dramatically, in the group that's detoxed, 20% of the participants have died of an overdose. So when we say that we'll just provide detoxification and not maintenance treatment, this is what we're essentially suggesting that we're doing. So I really want to make that point, right? And we've known for 2 decades now that addictions are similar to other chronic illnesses. We know, for example, that the genetic impact, the contribution of genes versus the contribution of environment, is no different from our substance use disorders compared to diabetes, asthma, and hypertension. We've known that relapse rates and treatment adherence rates are also no different between our SUDs and chronic illnesses, right? Therefore, long-term maintenance treatments are proven and effective, right? They're the most effective way to go. And yet we don't do that, right? Really, in many settings, that still remains something that's at times hard to find. So now, if you applied that to a patient with diabetes, right, the treatment we provide for our opioid use disorder patients, this is what it would look like. Your patient is in diabetic ketoacidosis, goes into hospital, or stays there for a few days, blood sugars are corrected, electrolytes are corrected, and if the patient is lucky, if the access is there, if beds are open, if the patient has the right kind of insurance, then the patient goes to a 28-day unit for people with diabetes, is taught how to eat healthy, exercise, and then discharge without any follow-up treatment. Can we imagine that? I mean, can any of you imagine that or think that that would be medically or ethically appropriate? And yet, unfortunately, this remains something that many of our patients encounter, right? So that's the implication, that as in all chronic diseases, treatment should be continuous and not episodic. And we know that available treatments lead to significant reductions in alcohol and drug use, increases in personal health, social well-being, things that point to recovery, right? Reductions in threats to public health and safety, reductions in monetary costs, and ultimately, reductions in mortality. These are our medications. These are the 3 medications that are approved by the FDA for treatment of opioid use disorder. That's it. Methadone, which is a full mu agonist, buprenorphine, which is a partial agonist, and naltrexone, both oral and injectable, which are antagonist treatments. So those are the treatments that are FDA approved for treatment. And I mentioned mortality. Look at this slide I put together. So compared to someone in the general population, a person with opioid use disorder who's not in treatment is about 6 times more likely to die. 6 times, right? And many of these patients we work with are young patients with bright futures ahead of them, and we lose them. Now, when we get them on maintenance treatment with either methadone or buprenorphine, this has not been shown with naltrexone yet, you can see how significantly the mortality rate comes down. Doesn't quite get back to 1, but comes down to about 1.7 or so. So significant reduction. I know there are some psychiatrists in the audience, and when I work with residents, I say, how many other medications do we have in psychiatry that can say that? I can't name one, right, that can show this kind of mortality reduction, and yet, their reluctance to treat. There are many other benefits, right? Medications are often one part of a more comprehensive treatment for many people. It can be the hook that draws people into treatment. It allows us to treat underlying illnesses, PTSD, hepatitis C, like it was mentioned. At our clinic, we've now treated, I think, close to 100 patients with hepatitis C, right, just within our clinic, and that also encourages them to stay in treatment, right? And it's sort of this one more step towards their recovery. It helps them stabilize their employment, their housing, right, other things, allows them to create positive social networks and gives them hope about their future, right? So how long should the treatment be? That's the other point I was asked to make. And that's the answer. For as long as it benefits the patient, right? Just like all of our other treatments, what I don't do is pressure my patient to come down off of the medication that's working for her, right? This is a slide. It's a few studies that are put together. What the green line is showing, or rather what the blue line is showing, is treatment retention with buprenorphine. So what we know is that a year out, about 60, 70% of people are still in treatment. And remember, staying in treatment is good. And as people stay in treatment, you can see that they increasingly stop using opioids. You can see that by a year out, about 80% of them are providing opioid-negative urines. So our medications allow people to stay in treatment, and the longer they stay in treatment, the less they use opioids. That's the take-home point that I'm making here. And yet, we know that most people who stop buprenorphine don't stop because they wanted to. What the data shows is that treatment is discontinued because of insurers' mandates. And thankfully, I think we're really lucky because of all the policy work that's been done that our Medicaid doesn't place these barriers, right? So we're lucky, but many of our patients in other states still deal with this. They're often discharged based on missed appointments, ongoing substance use, logistic conflicts, or conflicts with staff. So this is the suggested approach. We caution our patients from discontinuing treatment too early. That's another take-home point. That is evidence-based. Every major study has shown treatment retention improves outcomes, and brief withdrawal periods, detox alone, is unlikely to improve outcomes in any significant way. And what's the worst case scenario, right? If they stay in treatment, maybe the cost, maybe the stigma attached to it, but what if they stop the medication? Remember that slide. What happens to people when they stop treatment, right? When they stop the medication. So keep that in mind. This is the other question. Isn't it switching from one addiction to another? Remember that dependence, right? When we get used to a medication, our body gets used to it, is not a substance use disorder, right? Tolerance and withdrawal happen with lots of our medication, even some laxatives, right? But we don't say the person is addicted to the laxative. This is just a slide I put together comparing heroin and illicit opioids to naltrexone, methadone, and buprenorphine, right? Just comparing the two. And then, I'll let you guys just read it for a second and kind of asking, is this still exchanging one drug for another, right? We know outcomes are increased, high-risk behaviors go down, child support payments go up, right? There's less high-risk behaviors, there's less hepatitis C transmission, less HIV transmission, less incarceration, more employment, less needle sharing, less commercial sex work, right? Those are just some differences that I'll kind of point out. And finally, I want to end with this concept of stigma, recovery, and pharmacotherapy. We know, right, that recovery can often be the goal, and that's often what we promote, right? And this happens. At our clinic, I was going through the data, and a third of our patients with opioid use disorder are in long-term recovery. They're holding down jobs. They have families. They've completed GED. They've completed probation. We've had some who completed their PhDs. We don't hear about them. In our medical training, our students don't see these patients, right? So the stigma gets perpetuated, and we don't realize that recovery is possible, and it happens. And medications are an essential part of recovery with opioid use disorders. We know that, right? And we know that remission promoted by medications can lead to all these outcomes: improved health, reduced mortality, stable housing, purpose, employment, crime-free life, engagement in community, stable social networks, and ultimately hope, that self-efficacy. All of these are, not coincidentally, also essential components of recovery as defined by SAMHSA, right? So medications promote treatment adherence, which promotes recovery. However, there is a huge lack of buprenorphine providers, to the point you were making. This number has gone up. This was the biggest study that, really elegant study that was done, came out in 2014. At that point, only about 2% of all US physicians had a waiver, and most of them practice in urban or near urban areas. So when we think about our state that's largely rural, you can start seeing it. I think we've done a really good job bringing this number up, and I think with NPs and PAs, despite that 24-hour training, it's been projected that in the Mountain West, the access to buprenorphine may go up by about 20 to 25%, according to a recent paper that came out. So congratulations and thanks to you guys, right? Our advanced practice providers, for being here. And I'll leave you with this, right? disparate treatment. And how much does stigma play into this? I think SUDs, despite everything we've presented, are the only conditions in which non-compliance or lapse, recurrence of use are grounds for dismissal. Oh, you relapse, so you're kicked out of treatment. 3 strikes and you're out, right? Withholding known life-saving treatment is considered. Not all medications are offered, or only the less effective meds are offered, or they're withheld, they're rationed, or withheld based on personal morals, right? Active disease is considered crime and not illness. Patients are expected to discontinue effective treatment, even if it's working, and there might be limited insurance coverage. These recommendations just came out from the National Academy of Sciences. Opioid use disorder is a treatable chronic brain disease, right? That's one. Second, FDA-approved medications to treat OUDs are effective and save lives. Long-term retention on medications to treat opioid use disorder is associated with improved outcomes. A lack of availability of behavioral interventions, we all would love to have them, but if it's not available, it is not a sufficient justification to withhold treatment. Most people who could use and benefit from medication-based treatment do not receive it, and access is inequitable across subgroups of population, right? Minorities, women, LGBTQ populations have a harder time accessing it. Medication-based treatment is effective across all treatment settings studied to date, and withholding or failing to have available all classes of FDA-approved medications in any care or criminal justice setting is denying appropriate medical treatment. This is according to the National Academy of Sciences, and confronting the major barriers is critical to addressing the opioid crisis. So with that, I'm going to turn it over to Dr. Duhigg. Thank you.